So it's about troubleshooting for conduits. And it's a very simple step-by-step for each problem, what is the next. And every surgeon, I mean, who's doing an esophagectomy has faced this at some point. So the first thing is obviously to avoid all these problems is choosing your conduit properly for your surgery. I think the previous speakers have already elaborated, but for the younger surgeons, basically malignant, like our current topic, for esophagectomy, we would prefer the gastric. For benign, always we'd like to have the gastric reservoir, innervated gastric reservoir. We prefer the colon. Retrosternal is a longer route, prefer colon. Posterior mediastinal, gastric. And when we do the anastomosis at the neck, it's mostly gastric, but when you go up, higher up to the pharyngeal, whatever the situation is, we would prefer an esophageal, I mean colonic. So at the end of a long surgery, long and tiring surgery, this is the result which you would want to see. This is some surgery we did, I think, last week. You want the conduit to reach up to the neck and then some more extra, so that enough to revise, freshen the edges once again and have nice spurting vessels. But that's not always the case. So the common problems we'll look at is conduit not reaching, conduit dusky, and conduit necrosis, what to do in these situations. So the first thing is conduit not reaching. So the first step, if the conduit is not reaching, don't keep trying to pull it up harder, because there is only a couple of the, like in the context of the gastric conduit, it's only the left gastroepiploic vein and artery, the right gastroepiploic vein and artery which is supplying, and there could be tear and avulsion of the veins. And don't try to fix it to the prevertebral fascia, pulling it tight and fixing it, because an increased leak rate is there. So one is, of course, the problems can occur, inadequate length. We know all these things, previous gastric surgery, tube gastrostomy and all that. But other situations, even where an EMR has occurred, expect some fibrosis. A patient who's been on FJ for like, say, 3 months, 4 months during the neoadjuvant therapy, there's nothing distending the stomach over a period of time becomes very small and contracted. So these kind of situations, you can face these things. First step you do is do your basics, basically the gastric mobilization. I mean the antrum and what else to the right of the antrum, release all the lesser sac adhesions. The stomach and the mesocolon are frequently plastered, completely release all that. Then when you're pulling it up, actually many people, we just put one rise tube and try to pull it through. If the esophagus has not been divided, the gastric conduit can get hitched at the esophagus and get caught. So one way to avoid this and other venous tears when you're pulling is always do an over tube. Your ultrasound, the cover, the over tube, pull it across, fix the conduit in that and pull together with the over tube. That prevents this from getting hooked anywhere and also prevents tears. Next is a complete cauterization. The help with a complete cauterization is marginal, but whatever help it can do, an extended cauterization, to some degree it helps. The most important step is a right gastric vessel ligation. I know a lot of surgeons look at right gastric ligation as the last step in a gastric conduit, but the contribution of the right gastric vessels is insignificant. So you can safely, and in fact routinely if you want, divide it, but you don't need to divide routinely, but you should be very liberal at dividing the right gastric. But what that does is, the fixing point, the vessels are finally the fixing point. The fixing point will be the pylorus fixed by the right gastric vessels. Once you divide that, you'll get the pylorus gets freed, and then the fixing point will be the origin of the right gastroepiploic vessel. So be liberal dividing the right gastric vessels whenever you have such problem. Next is when it's still not reaching. You've done all this and it's still not reaching. First thing is, all these steps you should be mentally prepared. Like for example, you have a slightly scarred stomach, or you're doing a retrosternal gastric conduit for some reason. Ideally, these things should be usually prepared. One is making a narrow tube. I think Venkatraman already had mentioned ideal is 4 to 5, but even up to 3 centimeters, the results are equally good. There is studies which show, publications which are the patient who routinely made a 3 centimeter conduit. The results are equally good. So you can go down to a 3 centimeter conduit. The narrower the conduit, the lesser curve is 1/4 of the length of the greater curve. The narrower the conduit, the longer the length you get. And of course, these kind of the images which you see here. So you have to open up go below the incision and open up. The type 2 and 3 kind of conduits you can make when you're doing an intrathoracic anastomosis, but when you're doing a neck anastomosis, you will really need to go the horizontal with your first stapler and then do. One more trick is the these staplers, so the smaller the staplers, you use, actually here we have 45, in the West they also have 30 millimeter staplers. If you use smaller staplers firings, it lengthens it. If you use long, rather than using the 60 staplers. And all of us like to bury the gastric suture line. I think that is very important. If you've seen one case of intrathoracic bleed from the gastric conduit, after that you'll realize that it's mandatory to bury the suture line. We always do. And in that, avoid continuous suturing. Again, it's like a bow. The greater curve is like a bow that's being strung. And once you do a continuous suturing, again, it sort of reduces the distance. So even if it takes a bit of time, do interpret seriomuscular sutures. So these steps will make your conduit a bit longer. And if you have not already done this, you can still considering redoing your conduit, making it a narrower tube and going below in the incisura and smaller reduce. But ideally, these things should be done at the beginning when you expect a shorter conduit. Still not reaching. In our kind of situation, if it's still not reaching, I would seriously consider a colonic conduit, because there's something, as GI surgeons, we are used to it very commonly for corrosive strictures. We always prefer a left colonic conduit. Reason, it's a very straight route. The vascularity of the right colon marginal is not as reliable as the left, and the middle colic arteries sort of tend the colon and make it redundant, while the left colic is very straight, left colonic conduit is very straight.